Warm greetings to one and all. Let's wait for a couple of minutes while we admit the rest of them. Hope you all can hear my voice clearly. So once again, this is Dr. Anita Sargent, your MC for the session. If you wish to claim your certificate for the same, kindly visit our website, which is www.onlinedentistry.in/9 p.m. and register for the same. Once again, welcome back to the free online session of online dentistry at 9 p.m. with yet another amazing faculty. Online dentistry has been the pioneers in providing dental education via both online and offline platforms. The motto we preach is to redefine dental education. It has been established over 14 years, and that online dentistry have been conducting sessions for clinical practitioners across the globe. Established in the year 2008, so far we have covered over 2003 offline courses and we have conducted 1022 online courses with an enormous amount of more than 30,000 followers on our platform. Let me proudly introduce the CEO of online dentistry, Dr. Binuti Abraham, who is one of the finest practitioners in town, an orthodontist by profession, a passionate photographer, and he owns his private practice at Kerala Dental Clinic, Aluva. Moving on to the academic head of online dentistry, Professor Dr. Joby Peter. Currently, he is the HOD of Department of Pediatric Dentistry at Anu Dental College. He preaches the philosophy to catch them young and watch them grow. Over the years, we have grown dynamically, launching 10 centers in different parts of India. The latest addition to our courses, the one-year comprehensive and advanced master training program on interceptive and myofunctional orthodontics have been successfully initiated with 2 batches, and we are now open to take up students for the 3rd batch coming up in September 2023. This is a multidisciplinary approach with intense training and hands-on session under a team of eminent faculties, including our own Professor Dr. Joby Peter, Dr. Binuti Abraham, Dr. Monica Sharma, Dr. Shain Shakur, and Ms. Ahana. The registrations have started for the next batch, which commences on September 22nd, 23rd, and 24th. We are happy to announce that we are having only 2 more seats remaining. Another feather to our cap, a 3-day program is about to commence on 28th, 29th, and 30th of April at Kochi, which will be an amazing workshop on interceptive and myofunctional orthodontics. Yet another amazing session with Dr. Deepak Daryani is about to happen on the 18th, 19th, and the 21st of May, which is a paid online session on temporomandibular joint disorders and their management. Online dentistry have been conducting sessions all over India for the past 14 years. During the lockdown, we started conducting online sessions to benefit the practitioners, which have been received with great appreciation from the dental fraternity. In the year 2023, we are relaunching the same by providing free advanced learning series under the title Online Dentistry at 9 p.m. We'll be coming up with yet another amazing session on wisdom tooth removal simplified by Dr. Pravesh. You can always feel free to reach to us on our WhatsApp numbers, or you can visit our website, which is www.onlinedentistry.in, or else you can email to us on onlinedentistry.in@gmail.com. Without further ado, let me move on to introducing the speaker for the day. Dr. Deepak Daryani, BDS MDS. He's a professor and head of the Department of Oral Medicine and Radiology, Malabar Dental College and Research Center. Dr. Deepak Daryani completed his Masters in Oral Medicine and Radiology from A.B. Shetty Memorial Institute of Dental Science in 2007 under the Rajiv Gandhi University of Health Science. He has 15 years of undergraduate teaching and 12 years of postgraduate teaching experience. He is currently holding the post of Professor and Head of the Department of Oral Medicine and Radiology, Malabar Dental College and Research Center. Dr. Deepak is one of the very few dentists who has directed his efforts towards treating temporomandibular joint disorders conservatively with a lot of success. Dr. Deepak has formulated a unique protocol for management of TMDs by combining pharmacotherapy, occlusal spin therapy, physical therapies, and physical regulation techniques synergistically. He has modified the design of jaw stabilizing occlusal splint, which is orthopedically stable, which has been very effective in treating TMDs. He also conducts certified courses regarding management of temporomandibular joint disorders in general dental practice. He runs an exclusive TMJ clinic on HSR Dental Clinic and Implant Center, Bangalore. He has given several lectures nationally and internationally on the subject of TMDs. His other areas of interest include non-surgical laser therapy in management of mucosal lesions, management of geriatric patients, management of patients with xerostomia, and dental management of medically compromised patients. He is a certified implantologist and has keen interest in cosmetic dentistry and smile designing. Dr. Deepak has many national and international publications in reputed journals to his credit. He was in the editorial core committee of Journal of Indian Academy of Oral Medicine and Radiology, which is the DCI-recognized National Journal of Oral Medicine and Radiology, and also in the editorial committee of Malabar Dental College Journal. He has contributed significantly in the famous book by Dr. Shantipriya Reddy titled Essentials of Clinical Periodontology and Periodontics. Dr. Deepak has also fabricated modified calcium cup for the collection of exclusive unstimulated parotid saliva. Sir, we proudly welcome you to Online Dentistry, and the session is all yours.
Thank you, Dr. Anita, for those kind words and for the warm welcome. I hope I'm audible. Can I get a thumbs up, Doctor? Am I audible?
Yes, sir. You're audible, sir.
Great. At the outset, let me tell a happy Holi to all of you. Today is a very auspicious day. We have got Holi, as well as I would like to wish a very happy Women's Day to all the women in this group today. It's indeed a pleasure to be associated with Online Dentistry from past 4 years now. And to talk about the topic of temporomandibular disorder, which is very close to my heart. I have been doing a lot of research in this field since I was a PG, and I wanted to go into this field. It's indeed a pleasure to be talking about this topic, which I am very passionate about. Talking about temporomandibular disorders, it is considered as an enigmatic topic. It is in the gray shade of area in the dentistry. It is not very well understood. And most of all, temporomandibular disorder is a very big topic. Today, in this 1 hour, I will be making an attempt. I'll be making an attempt to tell the most important concepts associated with temporomandibular disorders, and then we will go into the important functional anatomy so as to refresh you all, and then go into the diagnosis of the most common TMDs, and then into the management which can be done at the level of general dental practice and at the level of a college in the department with the minimum of the equipments. Without any further ado, let's begin. Today's topic, I will call it as a curtain raiser, because I will be touching only the superficial aspect of it. It is impossible to cover the entire topic. So I'll try my best to introduce the most important concepts and the most important anatomy and the management. Let's begin. The human masticatory system is a product of millions of years of evolution, and it consists of an intricate balance between bone, cartilage, teeth, muscle, and ligament. This entire thing works in unison to give you a perfect masticatory system. However, our masticatory system gets loaded by a lot of factors, which I call it as events. The most important factor here is mastication. And then there are other events like trauma, stress, parafunctional habit, and deep pain input. All these things can trigger the muscle contraction, leading to change in the jaw position and ultimately leading to temporomandibular disorder. In short, if the sum total of this external load exceeds the load bearing capability of masticatory muscle, what results is temporomandibular disorder. In my practice, I came across some of the very few interesting things which I would like to share. 95% of the patient in my practice of TMDs are females. When I tried to search about it, why females suffer so much more as compared to male, there are two factors which I came across. Females has got a hormone which is called as estrogen. Estrogen laxes the ligament. Okay, it's the ligament of the TM joint which prevents the axis movement of the joint. Because of the presence of estrogen and the laxing of the ligament, it allows for a little bit more play as compared to males. And hence female tends to have more TMJ problems as compared to males. The second factor is the research says that the stress bearing capability of a female is lesser as compared to the male. And as we know that temporomandibular disorder is a psychosomatic disorder, this stress leads to increased muscle contraction, leading to the problems. Occlusal discrepancies accounts for 85% of the cases which I have seen. And it's a very important thing. Why? Because we dentists play with occlusion on daily basis. We change the occlusion on daily basis. And hence we play a very, very important role when it comes to TMDs. 70% of my patients has given the history of stress. This is very, very important. And let me tell you, 80% of my patients are young population, which is in the age group of around 25 to 35 years of age. Now, stress is important. We, later in the management protocol, I'll be talking about physical self-regulation technique, where we will talk about how to manage the stress. It's very, very important to address this issue, because unless you manage the stress of the patient, there are all the chances that there will be relapse of TMDs. But the most disturbing factor which I came across, 80 to 85% of the TMD cases which I have seen so far are iatrogenic. Means what? They are dentist induced. The person or the dentist who has called me to see the case has indirectly somehow induced the problem. This got me thinking. I saw this right from 2007. And this got me thinking that there is something going wrong. The basic education of TMJ itself is lacking in the dental community. And hence I started about, this programs like this, usually for general dental practitioners and for other dentists. Let me talk about this case. We will keep this case in mind throughout this presentation, and we will keep coming back to this case and how we are going to sort out this case. A 39-year-old female came to me. When I took the history, she said that she had a pain in 3/7 for which she went to a dentist. The dentist diagnosed it as a problem with the tooth and advised a root canal. The root canal was done and patient was very happy. The pain went off. And then the dentist advised the crown. She said, fine. She had the full faith in dentist. And dentist went about giving the metal crown, which you can see in this video. It was after that the crown was placed, she started feeling discomfort on the left side. She goes back again to the dentist. She says that I have difficulty in chewing. I have a problem with this crown because I feel it is a bit high. So he said, okay, no problem. He used an articulating paper, which she told me he used a colored paper, and he grinded the tooth, which made my tooth feel better. And now the doctor said, now the things should be fine. Even if there is here or there something, you'll get adjusted and everything will be fine. The patient says, okay, and she goes back. But after a few days, she again realizes that the problem is not going and some slight amount of pain is coming in the region of tooth as well as going towards the ear. So she starts eating towards the right side. As the dentist said, that things will get adjusted in a due course of time. So she starts eating from the other side. Okay. But the problem doesn't seem to go and the problem seemed to get elevated. The pain now has gone to the joint and is going to the head. And now when the patient goes back to the dentist and says that, doctor, I have got this problem which is going to the joint, that means towards the ear and towards the head. What to do now? Now the dentist doesn't know what to do. And he says that, I think you have got a TMJ problem, which most likely is not associated with tooth. And he refers the patient to me. Now, let me tell you here in this case, I know that there was a problem created after the dental treatment. Even the dentist knows that a problem has created, but he doesn't know what to do. Unfortunately, the patient also knows that everything was fine, but the problem got created after putting the crown. Okay. Now the patient has come to me with these complaints: continuous pain over the left region, left side, headache, severe pain on mouth opening, unable to chew from the left side. And when she tries to chew from the right side, also there is pain on the left side, pain in the neck, difficulty in sleeping due to pain. The diagnosis for the T37 was tender. So there was an apical periodontitis present in respect to 37. The lateral pterygoid muscles, temporalis and trapezius muscles were tender. They had developed trigger points. There was deflection seen. The jaw was going only towards one side and not coming back. That means that TMJ had deflection. The patient had deflection of the mandible, suffering from the condition called as anterior disc displacement without reduction. The position of the head and neck had tilted towards the left side. Patient was unable to eat, unable to sleep, and patient had constant headache unilaterally. And also she had neck pain. In short, there was a complete collapse of masticatory system. Now, where did the dentist go wrong? Let's find out. So what I did, I thought, let's find out where the dentist go wrong. So I used an articulating paper and I told the patient to bite on it at the maximum intercuspation. And look what I saw. All the functional cusps of all the mandibular teeth were coming in contact along with the crown. That means what? The dentist had did his job well. He had used the articulating paper. He checked in maximum intercuspation and he had reduced the crown. Then where was the problem? What actually went wrong? How a dental treatment led to the simultaneous involvement of tooth, TMJ, muscle, and led to headache as well, and how to manage. We are going to answer these questions in the upcoming slides. There are few concepts of the masticatory system which I'm going to talk about now, which I feel is a must for all dentists to know. Concept number one, the concept of disocclusion time. Sounds very confusing, but it is not. What is an occlusion? Occlusion is the precise contact at which the maxillary and mandibular teeth comes in contact. It is unique for each patient. What is disocclusion? It is the manner in which the teeth goes away from each other. And it can happen in three ways. Straight, when the patient opens his mouth directly, laterotrusive movements, and anterior protrusive guidance. You can see in the first video, this is the laterotrusive movements. And this is the anterior protrusive movement. So these are the ways in which mandible can disocclude. So when I checked the same thing in the patient, what I found, but before that, so what is more important, occlusion or disocclusion? Now, most of the dentists gives importance only to the occlusion, whereas disocclusion is as important as occlusion. When I checked in this patient, the laterotrusive movements by putting an articulating paper and telling the patient to do what is called as a canine guidance and also the anterior protrusive guidance, what I found was all the functional cusps, yes, they were coming in contact along with the functional cusps of the crown, but the other portions of the crown were also coming in contact. Meant what? It meant that when the patient was disoccluding, the teeth were getting disoccluded from other teeth immediately, but from this tooth, it was taking more time to getting disoccluded, and hence more pressure was getting applied to this tooth. Then I went about reducing that crown. And what I actually did was I reduced the disocclusion time. So what is the takeaway point here? No dental procedure should increase the disocclusion time. And how to make sure of that? For every patient, whatever restoration or prosthesis you have given, you must check for not only maximum intercuspation, but also the canine guidance and the anterior protrusive guidance and correct the restoration. Concept number 2, masticatory system always tries to achieve maximum efficiency. Remember, it is a survival of the fittest which nature follows. Okay, so our masticatory system is a product of millions of years of evolution. It is very, very accurate. It will always try to give the best. It will always tries to achieve the maximum efficiency of chewing. Healthy masticatory system is equivalent to bilateral chewing. Okay, so to manage our mastication throughout our life, we must eat equally from both the sides. If for some reason, if a teeth is missing or orthodontic treatment is going on, or you have given an improper restoration or a bridge or a crown, or you have done some dental treatment wherein because of which the patient is not able to eat from one side and started eating from the other side and has developed the habit of eating from the other side only, just imagine that the muscles which were meant to take half the load is taking the complete load of crushing, and the other muscle is doing the para function of shifting the food to the other side. So not only the side which is chewing can give away, the muscle, if it is weak, can give away, even the other side which is not chewing, but the muscles of that side is shifting, especially the lateral pterygoid, which helps in side to side movement. Constantly doing the same thing can give away, resulting in temporomandibular disorder. So what is the takeaway point here? After any treatment, make sure that patient is chewing bilaterally. How to do that? Even if you have done a simple filling, follow up with the patient. If you don't want to call them, it's okay. Just give them a call and ask whether you are able to eat equally from both the side or not. If patient says that they are not able to eat equally from both the side, ensure that they are able to eat. Otherwise, many of them or few of them, whoever are having other etiologies associated, including the stress, may succumb to TMDs. Concept number 3. This is very, very important concept. TMDs always have multiple etiologies. If a patient has come to you with a TMD, he is not going to have only a tooth problem or only a muscle problem or only a joint problem. There will be more than one system which would have collapsed and the patient would have come. In most likelihood, they will have multiple etiologies. Okay. Now, in this case, the problem started with the tooth, but now there is a muscle involvement. There is a joint involvement. There are other muscles of neck and the back which has also got involved. The position of the head has shifted. The position of the back or the hip has shifted. So there are multiple etiologies with which patient will come. Now, if you are just going to correct that tooth which initiated the change, is not going to solve the problem because you have just sorted out one etiology. Muscle, joint, everything has to be sorted out. Otherwise, the load will go to the other component and that will again break down, resulting in the relapse of TMDs. This is a very, very important concept, that TMDs always have a multiple etiologies, and the treatment also has to be simultaneously using multiple treatment modalities for treating TMDs. And there are various modalities which we'll be talking about in the due course in the further slides. Coming to the next concept, the concept of orthopedic stability. What do you mean by orthopedic stability? Orthopedic stability means that it is that position of maxilla to mandible when all the surrounding muscles are relaxed. Okay. And what is that? What is that relationship where all the muscles will be relaxed? What is the relationship of maxilla to mandible? That is called that centric relation. It is the most stable musculoskeletal position. It is that position where the condyle is pitched against the intermediate zone of the articular disc, and this condyle and articular disc complex is pitched against the posterior slope of the anterior articular eminence. What we called it as centric relation. It's a very, very important thing to be learned by every dentist and should be used routinely in your dental practice, whatever you are doing with the patient, whatever restorations or the prosthesis you are giving. Every dentist must know how to take a centric relation. There are various ways of taking centric relation, which wax to use, how to relax the muscle before you take the centric relation. Remember, centric relation is an aggressive movement. It is a relationship which you get by holding the mandible and pushing it posteriorly. Okay, and it should be learned by all the dentists. What is the takeaway point here? If the treatment does not provide orthopedic stability, if your dental treatment does not provide orthopedic stability, it's going to lead to TMDs. How to achieve it? For any CD, RPD, long span bridges, full mouth rehab, night guards. I will talk about night guards later. Orthotics. You have to take an interocclusal record at a orthopedically stable position. So you have to learn not only, see, centric relation is a very aggressive position. In many of the TMJ cases, you cannot take a centric relation because of the retrodiscitis and the increased pressure inside the intracapsular pressure. You cannot push the mandible posteriorly, and hence you need to learn the other techniques to record an orthopedically stable positions like neutral positions, which I will talk a little later. Coming to the next concept, again, I'm just taking most important because there are many, many more concepts. I have taken some few which is usually ignored and which should be always considered. Among all the component of masticatory system, the most important one is not the tooth, it is the muscle. Muscle has the maximum influence on the masticatory system. Muscle controls the masticatory system. It is the muscle which will finally define what position the skeletal will be, and hence what posture the patient is going to get. The proper body and head posture is a result of precise and complex tonicity and interaction of different muscles. So, if due to some reason one muscle gives away, the load is going to get to the other muscle, and eventually that muscle will give away, and then the load will go to the other muscle. This is what happens in some patients who are having multiple issues, which results in change in the head position, change in the walking position, and the complete collapse of one side of the body. A simple occlusal discrepancy can lead to increased stress on the muscle, and if that muscle is weak and associated with other etiologies like stress, can lead to the breakdown of that single muscle, resulting in the breaking down of multiple muscle, which can result in change in the head position or abnormal posture of the body, which can make the patient inability to walk fast, inability to balance the body while walking, bending of the body while sitting, standing, or walking. A single problem can lead to multiple problems, resulting in change in the gravity of the body, resulting in what is called as a hip drop gait or Trendelenburg gait. What is the takeaway point here? Consider muscular stability in every dental treatment performed. If you really want to practice the excellence in dentistry, you have to do this. And that's where it's one of the principles of neuromuscular dentistry. But it's very difficult to do that. How to achieve it? For achieving it, you need very precise instruments like T-scan and electromyography. Just to tell you, a T-scan, since I've used the word, T-scan is a precision instrument which measures the occlusion. It not only measures the occlusion very accurately, it can tell the point of contacts, at what point the first contact came, then the second, and then further contacts. It can also tell the timing and the amount of force which was applied over there. But alone, T-scan is not enough. Okay, so even if the T-scan tell you that this tooth is having more pressure than the other, you still need the humble articulating paper to find out which part of the tooth is high as compared to the other, which part of the tooth you are going to trim. So it's very important to learn how to use an articulating paper. And of course, T-scan is the next level by which you can measure, but alone T-scan is not enough. Okay, T-scan may say that the occlusion is proper, but the change in the occlusion may lead to muscle hyperactivity. In fact, one of the researchers says that in many of the orthodontic cases where the TMDs occur, it's because the orthodontist has not respected the muscle. He has gone about correcting the occlusion. Okay, he corrected the occlusion, but the change in the occlusion has led to hyperactivity of certain muscles. Okay, and if that patient is having other etiologies also, then he may succumb to the problem in that muscle. But how to measure that? How to measure that? You have changed the occlusion. You have done filling, you have changed the occlusion. You have put a bridge, you may have changed the occlusion. You have done ortho, definitely have changed the occlusion. How you are going to measure the muscle activity? So you have to integrate the electromyography machine along with the T-scan and measure every time you move the occlusion or change the occlusion. You need to measure all the masticatory muscles, whether they are working in their limit or not. If not, you may have to further change the treatment which you have done. It sounds complicated. It is. Okay, a single sensor of a T-scan costs 800 rupees, which can be used only for one patient. If you take the amount involved in T-scan plus electromyography, it will be costing you 13 lakh rupees, and you have to charge the same to the patient. Furthermore, 99% of the clinics in India does not have T-scan or electromyography. So what to do? What are the alternatives in our dental clinic or in our dental colleges for that matter? I seriously recommend that all dental colleges at least should have an electromyography, at least one in the whole college, because it is going to get used by so many people: orthodontist, prosthodontist, oral medicine, periodontist, and of course T-scan. Very useful for orthodontists, prosthodontists, and even for oral medicine. So we don't have that. So what to do? So the nearest replacement of T-scan is articulating paper. So you must learn the art of how to use the articulating paper, which articulating paper to use, which color to use for what should be the thickness of articulating paper. All this needs to be learned. And the closest thing which we can come to near to the electromyography is how to record an orthopedically stable position. That means the centric relation, which I talked about before. You have to learn the art of recording centric relation, which you have done that, but most of the people don't do it in their practice. And in TMDs, you have to learn other methods also, because centric relation is an aggressive position. And in TMDs, you may not be able to use those aggressive position, because when you are aggressively moving the mandible and the muscle is tender, if the pain comes, then immediately the muscle will undergo contraction and you will never get an orthopedically stable position, because orthopedically stable position is by definition a position where all the muscles are relaxed. It is that position of maxilla to mandible when all the muscles are relaxed. Coming to the last concept, a very important one, if you are interested in treating TMDs, the equation of TMDs. This is the equation. Normal function. What is the normal function? Chewing. And we can never stop it. We have to eat. Okay. This is going to load the joint. And then there are other events which can also load the joint, like occlusal factors, emotional stress, external trauma, micro trauma and macro trauma, deep pain inputs, and parafunctional activities. All these are the other events which can load the masticatory system. And if the sum total of this load is less than the physiological tolerance of teeth, muscle, ligament, or the bone, then what results is TMDs. If it is less than the physiological tolerance, no TMDs. If it is more than the physiological tolerance, TMDs. This is a slide which explains this. So this is Jim Carrey who's chewing. This is a normal function. And then a trauma occurs. But trauma is not great. The sum total of these events is less than the physiological tolerance. No problem. Jim Carrey keeps laughing and going about doing his job. However, if the sum total of these two is more than the physiological tolerance, then what happens is TMDs. So what is the takeaway point here? How can you manage TMDs? It can be managed by two ways. Okay. The first way is diagnose what all the events which are there. You can definitely not bring down the normal activity chewing. So we'll try to keep the chewing normal. Okay. But you'll try to find out what are the other events which are taking place in this patient. Try to eliminate them or reduce them. This is one thing you can do so that load on the masticatory system comes down. However, you can do another thing also, and you cannot reduce all the events. It's easy to say that reduce the stress, but the external environment is such that you cannot reduce the stress because stress is never external. Stress is internal, and this has to be taught to the patient. What is the stress? Stress is the response of an individual to the changing in the external environment. And it is different for different people. If a lion comes in front of you, you may run away, I may fight the lion. So it's the response, okay? And it cannot be made zero. So the next thing what we can do is, if somehow we can increase the physiological tolerance of the masticatory system, so even if the sum of the events persist, the load is more, if the physiological tolerance goes up, then still we can fight, the body can fight, can adapt, and there won't be any TMDs. This is the principle on which we'll be working. How to achieve it? We have to find out these events. It's an art to find out this event. You have to learn. It's a big skill. It's not easy. Find out these events and eliminate them. And increase the physiological tolerance. It's one of the toughest thing to do, but the only thing which can prevent the relapse, like strengthening the muscle, balance. We will talk about it a little later. And, you have to actually change the complete lifestyle of the patient. With this concept, let's go to the next part because we need to touch down upon all the aspects of TMDs. I will go and talk about, I'm not going to talk about the muscles and ligaments here. You know about it. And the time doesn't allow me to talk into detail. So I'll talk about the things which you might, if you're not a oral medicine person, or if you have not been interested, you might not be knowing. So I'll just point out those important things so that when I talk about the diagnosis and management, you can relate to this. So this is the TMJ, where the condyle is articulating with the glenoid fossa, which is a part of the skull. Remember, maxilla never moves. It's only the mandible which moves. And it's a compound joint because there's a presence of articular disc in between. So it makes it a compound joint. The articular disc acts like a third bone, but actually it's not a bone. It's a non-calcified fibrocartilage. Okay. And this is the ligament. There are so many ligaments involved here. I'll talk about this ligament because it's very important for you to know. It's called as capsular ligament. It surrounds the TMJ, and its function is to prevent the axis movement of the TM joint. Okay, it's called as capsular ligament. I will be classifying, for all the simplicity, I'll be classifying the entire TMDs into two parts. Okay, extracapsular TMDs and intracapsular TMD. So that's why this capsule is important. Let's cut this capsule and throw it away and see what's inside. Okay, the inside is an articular disc. Okay, it has got a bigger posterior end and a smaller anterior end, and the condyle articulates in the intermediate zone. This is the retrodiscal lamina. It's a very weak tissue. Against it is a lateral pterygoid muscle and superior and inferior lateral pterygoid muscle. So in front of this is muscle. One side the muscle is pulling the disc and the condyle. On the other side is a very, very humble retrodiscal lamina. Retrodiscal lamina are elastic collagen fibers. They don't have much strength. So when the lateral pterygoids, which you can see here, the red ones, okay, these are the superior lateral, this is the superior lateral pterygoid and this is the inferior lateral pterygoid. When they contract, they pull the condyle and the articular disc, and retrodiscal lamina cannot do anything. it just allows it to go. It's only when this muscle relaxes, the function of retrodiscal lamina is to pull the disc back. Okay. Now coming to the lateral, superior lateral pterygoid muscle and inferior lateral pterygoid muscle, we have read that lateral pterygoid muscle helps in opening the jaw, protrusion, and side to side movement. This is what Chaurasia taught us. Okay. And this is what we know, but it's not true, because lateral pterygoid muscle has got two parts, the superior head and the inferior head. Okay. The superior lateral pterygoid muscle acts totally opposite as compared to the inferior lateral pterygoid muscle. They are actually they act like two different muscles. The superior lateral pterygoid muscle acts in the power stroke. For example, if you take a almond and grab it, okay, after grabbing it between the upper and lower tooth, you crush it. This crushing is called as power stroke, which is done by superior lateral pterygoid. Whereas inferior lateral pterygoid does that conventional what we learned before, opening the jaw, protrusion of the jaw, and side to side movement. This is the inferior joint space, which helps in the hinge movement, and there's a superior joint place where there is a translatory movement, where the condyle and the articular disc complex moves. So that's why the TM joint has got two movements, the hinge movement and the translatory movement. That's why it's called as ganglionoarthroidal joint as well. This is how it looks in the cadaver. Okay, so this is a normal joint. The moment you want to open the mouth, the brain orders the lateral pterygoid muscle. It starts contracting, pulling the articular disc as well as the condyle forward. Let's see how it looks. Now, this is a very, very famous video which made us to visualize how naturally the condyle moves. Okay. I hope you all can see this clearly. There is condyle, in between there's articular disc, there's a glenoid fossa and the anterior articular eminence. However, this is an iconic video, but this is not at all true, okay, because this is a cadaver which was cut and somebody is moving the condyle. There's no brain which is triggering the muscle to contract. Actual movement is much, much more complex. There's not going to be only an anterior posterior movement. There's going to be some medial movement. There are other muscles which will be pulling it in the other direction. The actual movement is much, much more complex. Let's go to the diagnosis part. So to simplify the diagnosis part, I will talk about 6 decision making and 5 tools which we can use in diagnosis. The first decision what we have to make is the pain with which patient has come is a physical pain, or is a psychological pain, or is it both? Okay. Now we know that TMDs is a psychosomatic problem. There is a psychosomatic component associated with it. And in most of the cases, there is going to be a physical pain, but also there is going to be a psychological pain. Means there is going to be both. So you must know how much is the psychological component involved. So this decision is very, very important to make. And the second decision is whether you can treat the case on your own, or you can treat the case with the help of some other specialists like ENT specialist or orthopedician or a psychiatrist. Or you cannot treat. There are some cases which you cannot treat, which I sent away, like developmental anomalies of TMDs, like Treacher-Collins syndrome and all that. We cannot. We can contribute, but we'll need, most of the things will be done by other specialists. Whereas 80 to 90% of the cases we can treat on your own. The most common TMDs which will be walking in your clinic or in your dental college, definitely 98% cases you can treat with the help of certain other specialists. So what for these decision 1 and decision 2, the tool which I will recommend is a questionnaire. Okay, you must have a questionnaire because you must be able to assess how much is the psychological pain involved, how much is the physical pain involved, and whether you can actually treat this case or not. After a lot of research, I have made my own questionnaire by reading a lot of books, and I keep adding the questions to it as per my experience. The questions are based on the pain, the type of pain, the character of pain, the progression of pain, the radiation of pain, the timing of pain. Okay, then the stress, there are questions related to stress, parafunction, very, very important. There are certain systemic conditions which can mimic TMDs. Okay, we must know about them, like trigeminal neuralgia, sometimes fibromyalgia, which you cannot treat on your own. You'll need the help of other specialists. The questions related to chewing, to find out how the person is chewing. So you should have a questionnaire ready. And very important is sleep as well. We need to work upon the sleep. Sleep is a very, very important component which we need to work in future to prevent the relapse and to strengthen the body. So by this, we can assess the problems which we can treat. For example, there are psychological type A personalities or type B personalities. Most of these cases like perfectionist, compulsive, dominating, anxious, we can treat. Okay, there are some cases of anxiety, depression, history of physical or sexual abuse and secondary gain, which we cannot treat alone, but which we can treat with the help of a psychiatrist or a counselor. Okay. And then fibromyalgia, you may need help of other specialists, ENT specialists. You may need their help to eliminate, to find out if there is any other problems involved and to treat that. Coming to the next decision number 3. Remember the capsule I talked about? So we will divide the entire TMDs into 2 parts. I'm talking about the most common TMDs, the 90% or 95% of the cases which will come to you will have these problems. Okay, so let's divide them into 2 parts. Intracapsular disorder, all the disorder including the capsule, which is inside the capsule, is considered as intracapsular disorder, and everything outside is considered as extracapsular disorder, and outside is nothing but muscles. So if it's an intracapsular disorder, then it can be inflammatory joint disease like capsulitis. This capsule gets inflamed. Synovitis, our TM joint is also a synovial joint. The inflammation of synovial membrane is called as synovitis, which can also cause pain. Retrodiscitis and arthritis. And the second part can be the internal derangement of TMJ, which can be disc displacement or dislocation disorders with or without reduction. Okay, very simple. The intracapsular disorders, most common one can be divided into inflammatory joint disease and internal derangement of the TMJ. How to find out? The tool number 2, to find out what kind of a TMJ problem it is, you must learn how to do a TMJ examination. The TMJ examination can be divided into 2 parts, intra-auricular part and extra-auricular part. The intra-auricular part will tell you certain things, like it will help you in diagnosing retrodiscitis, the posterior aspect of the TMJ issues, okay, increased intra-auricular pressure. If there is a condylar fracture, you can assess by using intra-auricular examination. Whereas pre-auricular or extra-auricular examination will help you to find out the pain related to the capsule. It can find out you can feel the sounds. Is it a popping sound? Is it a clicking sound? Is it a grating sound? Or is it a thud sound? Each sound signifies different kind of problems, like is it an internal derangement, which is the most common related to clicking? Is it a thud, which is related to the hypermobility? Is it the grating sound, which is related to arthritis? Or it is a popping sound, which is related to the dislocation of joint itself? You also must know the extra-auricular examination also includes how is the movement of the jaw. In this case, you can see that the jaw is going towards the right side and then coming into the center. And it is usually associated with the click. And you can see in this cadaver video, when the patient tries to open the mouth, there occurs a click. Okay, and the jaw is actually going to one side and suddenly it comes back. So this is called as deviation. It is usually associated with anterior disc displacement with reduction. The other case, which we took an example before, where the patient was really suffering, the mouth opening was restricted. When the patient is trying to open the mouth, it's going only toward one side, severe pain. If you see in this cadaver video, when the patient tries to open the mouth, the disc is not reducing. When the disc doesn't reduce, there won't be any clicking sound. So usually the deflection, which is associated with anterior disc displacement without reduction, will have no clicking. It's a more problematic situation. Coming to the next, I know I'm going fast, but we need a greater understanding of this subject. We need more time for this. My duty is today to let you know everything about TMDs. Going to the next decision number 5. If it's an extracapsular disorder, then that means the muscular disorder. Okay, so which all muscles are involved? Remember that when the patient has come to you, there will be multiple etiologies and mostly there will be multiple muscle involvement. One of the most common problems which I see nowadays is myofascial pain, which is associated with trigger points. Trigger points are the hyperalgesic points within the muscle. Okay, and usually patient will have multiple trigger points. So you must learn this ability to examine these muscles. And not only the muscles of mastication, that is masseter, lateral, medial, pterygoid, and temporalis. You must also know the neck muscle, trapezius, splenius capitis. Splenius capitis is one of the most important muscles which gets involved with TMDs, and the back muscles as well, because you have to palpate them. You have to find out which all muscles are involved. You have to find out which all trigger points are involved, and you have to eliminate all of them. Even if you leave one of the trigger points, that trigger point will be the constant source of pain, which will keep irritating the central nervous system, resulting in central nervous system excitation and resulting in what is called as referred pain. The pain can go to other places, then other trigger points can also form. This is one of a very interesting tool, which I call as concept of end feel. It is a tool by which you can learn what is the cause of restriction. Is it a soft tissue cause like muscle? Or is it a hard tissue cause like the articular disc? Another tool, very, very easy tools. All the things what I'm talking about here can be done at the level of general dental practice, at the level of any oral medicine clinic or any clinic in the dental college. Okay. Separators, I use usually ice cream stick as a separator. A separator is nothing but something which can separate the maxilla to mandible. It's a very, very important tool. By learning simple trick, you can use separator to find out the diagnosis, whether the pain occurring in the preauricular region is coming from within the capsular, it is an intracapsular pain, or extracapsular pain. Okay, so there are some tricks which we can do with the help of separators to find out whether it's an intra-articular pain, like is there an increased intra-articular pressure. So the separator will prevent that, hence the pain will not come. Okay. But if it's coming from inferior alveolar, from inferior lateral pterygoid muscle, you can just protrude the jaw after biting the separator. And if the pain was coming from the inferior lateral pterygoid muscle, it will pain. And hence you can differentiate between what is the source of pain in the preauricular region. Is it the inferior lateral pterygoid muscle or is it the intracapsular pain? Coming to the next decision, choosing the combination of treatment modalities. Okay, there are few combinations which I'll be talking about today, like pharmacotherapy, functional manipulation of jaw, occlusal splint therapy, physical therapy, and physical self-regulation technique. The next decision you have to choose is which one to use, for how long to use. Okay, so this is the next decision which you have to make. We'll talk about this in the last session of the talk today, that is management of TMDs. There are 5 treatment modalities which I'll talk about in the management of TMDs. First one, the functional manipulation of jaw. What is functional manipulation of jaw? We can maneuver the mandible. Remember that only mandible can move. Okay, maxilla cannot move. It is stationary. We can manipulate the mandible in a certain way to achieve certain results. By that, I mean, we can manipulate mandible to stretch the lateral pterygoid muscle and relax it. We can reduce the dislocated articular disc. For example, in the case which I discussed, the patient had disc dislocation, that is anterior disc dislocation without reduction. We can easily reduce it by learning this functional manipulation of the jaw. Immediately the pain will go away. The deflection which was there will convert into a deviation. The mouth opening will immediately increase. You can reduce the intra-articular pressure by maneuvering the mandible. And of course, you have learned you can reduce the dislocated condyle by maneuvering the mandible. Okay. Now this is associated with TMDs. But you know what? You can learn functional manipulation of jaw and you can use it before you record centric relation, which you will be doing for any other case also. So whenever you record centric relation, if you truly want to record a good centric relation, you must relax the patient. You must relax the muscle. And hence you have to learn the functional manipulation of the jaw before you do the centric relation. Modality number 2, pharmacotherapy. So this is the modality which is most commonly used and one which I try to eliminate as early as possible. Okay. I don't think I get any patient who has not gone by themselves, has taken a medicine, or they have gone to other dentists where either analgesic was given or a muscle relaxant was given. It is very important. Pharmacotherapy is very important, but it has got its own side effect. Okay. You cannot keep giving it. I give it for maximum 5 days to 7 days. And which pharmacotherapy to be used, which medicines to be used. NSAIDs, yes. Which NSAIDs to use? Muscle relaxant, you have to use centrally acting muscle relaxant. Which one? And you cannot, so all of these have got some side effects associated. So you cannot keep giving it for a long time. I highly depend on opioids. I think opioids are one of the best pharmacotherapy you can use for TMDs. It's a euphoric medicine. It relaxes the muscle. It reduces the anxiety. It increases the deep sleep, what is required. I also use tricyclic antidepressants, not in the dose which is given for antidepressant. You can bring down the dose and you can give it, because especially if the patient has parafunctions like bruxism, and that is causing a big problem for you to treat TMDs, you can introduce TCAs initially because it induces the deep sleep, it reduces the REM sleep. So TCAs is also a very important medicine to be used in TMDs. Now, this is one of the most important things which I feel is required, occlusal splint therapy. And when I say occlusal splint therapy, it is not something which we just take an upper and lower impression and send it to the lab, and lab makes it whatever they want and you give it to the patient. No, I am talking about orthotic. What is an orthotic? Orthotic is a prosthetic appliance which, when worn, creates orthopedic stability. If you use it for the lower back muscle, lower back, you can use a strap or a scrape bandage for the ankle. That is an orthotic. You can use a sole for the under the flat, for the flat foot. That is an orthotic. So the appliance which we use in the oral cavity is the occlusal splint, okay? But it has to be orthotic. Means what? It should create orthopedic stability. That's why I talked about this concept in the beginning, the concept of orthopedic stability. So what are the two different types, main type of orthotics which we can use? The first one is muscle relaxing appliance or jaw stabilizing appliance, and second one is anterior positioning appliance. So nowadays I see a lot of prefab. What a doctor does is, whenever a TMJ cases comes, they will just take an upper and lower and they call it a deprogrammer. Okay. What is a deprogrammer? It is an anterior bite plane. Anterior bite plane. Okay. It is not good at all to give an anterior bite plane for long term, maximum for 15 days. Some people give anterior positioning appliance. You have to be very careful when you are giving an anterior positioning appliance, and there are very few indications for that. Even if you are giving it, you have to modify it so that all the functional cusps are coming in contact. Otherwise, in the long term, you may create a malocclusion by using an anterior positioning appliance. We must learn how to make a muscle relaxing appliance or a jaw stabilizing appliance. For that, you need a centric relation. Okay, but as I said, that centric relation cannot be used in all cases of temporomandibular disorders because of the increased intra-articular pressure, or because of the because of the retrodiscitis. You cannot push the mandible back. So there is a position which was described by Dr. Wright called as neutral position. It's a very, very passive position where you actually don't push the mandible behind. You just guide the mandible. And this has become my favorite orthopedically stable position. It can be recorded in all kinds of cases. Which material to use? Whether you use a soft splint, whether you use a hard splint, which kind of hard splint? Whether you use acrylic, whether you use Valplast, Ivoclap, or you use your dual laminate. So each one has indication. I personally don't like soft splint. According to me, it's of no use. Whether to give a maxillary or mandibular splint, again, depends upon the cases. If the patient is very aesthetic conscious, you have to give a mandible splint. But otherwise, you can go for a maxillary splint. Maxillary splints are more stable. It doesn't cause much speech impingement, doesn't cause much salivation. Okay, but most of the patients are young patients, so they opt for mandibular splint. Whether the split should be partial or complete, never give a partial splint. So that's why I have seen so many dentists giving the lab gives them as a deprogrammer. They have not done anything. It's called as a deprogrammer. So what happens, there is an anterior plane. Only the anterior teeth comes in contact and the posterior teeth doesn't come in contact. Don't give any partial appliance, because in long term that can create a lot of problems. Okay, it can cause malocclusion. If the patient is having a parafunction like bruxism and you give a splint like that, just imagine the patient bites only on the anterior teeth. The anterior teeth mobility will happen in long term. What should be the thickness? Again, it varies from patient to patient, how much muscle relaxation you want to give. Again, you cannot give very thick. I don't think that you should give any time a posterior thickness more than 3.5 millimeter. Extensions, depending upon how to give extension, how much of retention is required. If you are going for an SX retainer and it is given beyond, if on the SX retainer you have put the acrylic and made a orthotic, and you have not blocked the undercuts, it can really become a big problem. You fix the splint, but it won't come out. So you have to see how much extensions are required. Occlusal surface, for all practical purposes, keep the occlusal surface flat. Do not leave any indentation, because during the lateral excursion, if it gets hindered, it can actually induce TMDs. Almost every time when a patient, when a lab sends you the splint, it will never be proper. You have to learn the art of balancing the splint, where you need the articulating paper, and you have to, this is the most tedious job among all when you are giving the splint, to sit. It will take around 45 minutes to 1 hour to sit with the patient and adjust the splint and give a perfect splint where all the functional cusp of the opposing arch is coming in contact with the flat occlusal plane. Delivery of the appliance, very, very important. You have to tell the patient how to use the appliance, how long to use, when not to use, how to maintain the appliance, and you have to do regular follow-ups with that. This example I wanted to give about night guard. What do we do? Almost all of us give night guard, right? What we do about night guard? We just take an upper or lower impression, or we just take one impression and the lab makes a night guard. What happens with such night guard? This patient was given night guard, okay? When the patient bites, only the posterior teeth comes in contact. Remember that when we normally bite, we create the forces, posteriorly the forces comes to around 70 to 100 kgs. But during bruxism, the forces as high as 300 kgs has been recorded. If a patient is having bruxism and you have given a night guard where only the posterior teeth is coming in contact, because the night guard which you have given is made in the lab and which is of uniform thickness, only the posterior teeth will come in contact. All the load goes in the posterior teeth. The worst is the anterior bite plane, which is given as a deprogrammer. The anterior teeth does not have any strength, so they will definitely become loose. But even the posterior teeth, if so much of load is given throughout the night on the posterior teeth, it can lead to TM joint issues if the patient is having other etiologies. Instead, you can give a muscle relaxing or a jaw stabilizing appliance as a night guard. That will be a perfect night guard, because all the teeth will be coming in contact and no excess pressure will be given to one tooth only. Next modality, physical therapies or physiotherapies. These are the most important modalities which will help you to eliminate trigger points, okay? And it consists of thermotherapy. You should know how to give thermotherapy, how long to give it, and how to use it along with the coolant therapy or the massage therapy, okay? Usually I use the combination of 3 and it can be done anywhere. It's very, very effective. The coolant therapy can relax the muscle immediately, especially if there's an acute injury. Cryotherapy is the go-to therapy. If it's a chronic injury, the hot therapy helps. Massage therapy in combination with these two are excellent. You have to learn the passive muscle stretching techniques and active muscle stretching techniques. It helps to stretch the muscle. Remember that when the muscle has undergone spasm, that means it is in a constant phase of contraction. When you go to gym and take a big load, first day you go and take 5 kg load, when you go home, your hand will not flex. So what does the gym instructor does? After you finish the exercise, he will stretch your bicep. What does stretching do? See, either you can relax the muscle by taking a muscle relaxant, which will dull the brain, centrally acting muscle relaxant, or you can stretch that muscle and relax it. This is the go-to therapy nowadays. We are doing a lot of research. My PGs are doing a lot of research with the laser therapy. I personally use a lot of laser therapy and it works wonders. Our current research which is going on is comparing the result of laser therapy with diclofenac sodium, and the pain relieving capability of laser therapy is equivalent to diclofenac sodium without the disadvantages of diclofenac sodium. And the mouth opening capability after using the laser is more than that of diclofenac sodium. So laser therapy is having this is the diode laser which I use. I will recommend it to be used for most of the trigger point elimination for muscle relaxation. Sometimes the pain doesn't go, the trigger point doesn't go. They are very, very stubborn. And remember, we have to eliminate all the trigger points. So you have to learn how to remove these stubborn trigger points. You can with the help of trigger point injections by giving local anesthesia into the site of trigger point. Coming to the last treatment modality, physical self-regulation therapy. It is the method by which we increase the physiological tolerance of the body. It consists of muscle strengthening, posture improvement, sleep. You have to go into the learning how the sleep, what is a sleep, what is an REM, what is a conscious mind, what is a subconscious mind, what is a deep sleep. You have to go into the breathing, how the patient breathes, very, very important to find out the airway spaces, if there are anything associated with that. Mastication, how is the patient chewing, and to change them if required. Behavioral modification and stress management, a very, very important one, because most common etiological factors in TMDs is stress. So you must learn the behavioral modification technique and stress management. Basically, you go about disciplining the entire lifestyle of the patient. You have to teach how to strengthen the muscle. The masticatory muscle strengthening, not only masticatory muscle strengthening, you have to teach the patient how to strengthen the neck muscles as well as the back muscles. Remember, all the muscle works in unison to give a proper posture to the patient, and we have to strengthen all of them. Otherwise, if one of the muscle also succumb, the load can go to the other one and lead to the problem again. Follow-ups, 4 to 5 follow-ups over a period of 1 month is a minimum for any kind of TMDs. In these follow-ups, we assess how is the stress coming down, how is the pain coming down, how are the symptoms coming down, and most of the symptoms cannot be measured, and only way it can be measured is by visual analog scale. So you have to take visual analog scale before you start the therapy and in every follow-up. To summarize, we have spoken, I have taken more than an hour. I will quickly summarize. We have talked about 6 basic concepts of TMDs, 6 decision-making, 5 tools for diagnosing TMDs, and 5 treatment modalities. Is this skill important? I think it's a very, very important skill if you want to practice excellence in dentistry. It will add value to your practice. You don't have to send the patient away. It will increase the confidence. Forget about that. If you learn this skill, you will not work only as an endodontist. You will not work only as a periodontist. You will not work only as an orthodontist. You will see patient as a whole, which is very, very important. You don't have to refer TMDs elsewhere. It will increase the confidence of patient to you. Believe me, I truly believe all of this. That's why I have written it here. And of course, if that doesn't attract you, you can earn a lot of money out of it. How to achieve this skill? Okay. What we have done today is just touch the tip of the iceberg. It's the trailer. And, the full movie includes the many other concepts, the examination details, learning how to examine TMJ, learning how to examine the muscles of mastication. Imaging I have not talked about today. Most of the TMJ cases are soft tissue based. That's why I've not talked about, but some of them are hard tissue, and you should know how to exclude hard tissue pathology from soft tissue, and you need imaging, how to read an OPG, how to read a CBCT, how and when to advise an MRI. Diagnosis, we have to go into depth of diagnosis, treatment protocol, how to fabricate an orthotic, how to give a balanced jaw stabilizing or a muscle relaxing appliance, which can also be used as a night guard, and follow-up rituals. We are coming up with this session, which earlier doctor spoke about, and usually the sessions we do here consist of 3 days. In the day one, we talked about the applied functional anatomy and muscle physiology. In day two, we talked in depth about examination and diagnosis. And in day three, we go about having 2 sessions, basic concepts, treatment planning, and we do different type of case discussion. And in the final session, we take up each treatment modality, and we talk about that, how to manage the TMD cases, how to do follow-ups, and how to address relapse. The aim of today's presentation was to give a brief knowledge about temporomandibular disorders and motivate the general dentist to start looking at temporomandibular disorders in a different light. And most important aim was to help dentists not induce TMDs, because most of the TMDs are iatrogenic. Okay. With this, I end my session. I acknowledge online dentistry for providing this with this platform where I can sit here and talk and give the knowledge and interact with the patient. We can have a Q&A session now. If there are any questions, I can take it up now. Thank you all so much.
Thank you, sir. It was indeed a wonderful session. So, sir, we have a question from the chat box. Dr. Anushree has asked this question. What happens to the TMJ when there is a surgical impaction where more time is taken for extraction? Does it create TMD problems? And does it potentiate TMD problems if he already has external events of stress?
Absolutely, it can. So, doctor, any kind of an exaggerated stress, if it is given to the joint or the muscle can succumb depending upon. Now you're a patient, you would have done 100 extractions, okay, 100 impactions. Out of that, 2 may succumb. Why these 2 patients? That's because their physiological tolerance was low. That person may be having some other kind of stress issue. She may not be sleeping well. Her musculoskeletal structure will be weak. There will be other etiologies because of which this etiology is added to it, resulting in the TMDs. I hope you get my point.
Yes, sir. Actually, we're not having more questions, I think, sir. Oh, sir. She have come up again, so that the treatment plan will go through these 5 actions that you mentioned.
Yeah, first we have to diagnose, doctor. We have to diagnose what kind of problem patient is facing. Is it just a myospasm? While doing an most common problem which happens after a disimpaction is pain, mouth opening restriction, and swelling. Okay, the mouth opening restriction happens because of the trauma. The muscle has undergone spasm, which can be easily treated with the help of exercises, with the help of physiotherapy. So you can do you don't have to give a splint here, just give physiotherapy, the mouth opening exercises, the thermotherapy, massage therapy, coolant therapy will help. We don't have to give the entire TMD therapy need not to be done unless there are other factors which gets involved and patient develops myofascial pain or temporomandibular joint disorder.
Thank you, sir. So next question from Dr. Bhanupriya. So can you explain about proper usage of articulation papers, red and blue?
It is a whole session which I have to take for articulating paper. So you must understand for that what is an occlusion, what are the different types of occlusion. There is a static occlusion and there is a dynamic occlusion. There is when you can use the paper and the the thickness of the paper depending upon what you want to achieve. So it's a bit lengthy process, which needs more time. And usually if virtually I do a demo, I give a demo of that. If we are doing a virtual session, then we need how to do it, how you should know what is a canine guidance, you should know what is an anterior protrusive guidance, and then you can use two different articulating paper and then then do what is called as a selective grinding. So it's a very, very lengthy topic, use of articulating paper. We shall do it sometime.
Thank you, sir. The next question, sir, from Mr. Baji. Which muscles relaxant works better, sir? And also which opioid is better, sir?
Which muscle relaxant works better? Always a centrally acting muscle relaxant. My favorite is chlorzoxazone in combination with diclofenac sodium and paracetamol. Okay, if you can get a combination of chlorzoxazone with diclofenac sodium and paracetamol, this synergistically act really well. You can use that. Opioid, always diazepam. 5 milligram diazepam at night works wonders. But remember that diazepam is not an over-the-counter drug, is an addictive drug. The patient is already stressed. He can become habitual to your diazepam or any anti-anxiety like alprazolam if you are giving. So you have to be careful with this.
Thank you, sir. So next question, sir, from Dr. Anushree itself. Thank you, sir. Understood. What about after IMF has been opened and the hypermobility of the muscles are there? Can this also potentiate TMD issues? And if so, is there any particular care that we can take to prevent it?
I did not understand. What has been opened? Intermaxillary fixation
IMF.
has
Yes,
been opened. Okay.
IMF.
Okay, then?
Has been opened.
Hypermobility
hypermobility of the muscles are there.
Yes.
So can this also potentiate TMD issues?
No, I don't think so. No, it's like when you have done, for example, if there is the hand gets broken and you put a cast, the entire muscle becomes weak. You start on physiotherapy, right? And you correct it. Same thing here. The muscle has become weak. You start on physiotherapy. Okay, we will start on physiotherapy and things should be fine. That need not go to TMDs.
Okay, sir. And if so, is there any particular care that we can take to prevent it?
Yeah, one of the most important thing is after IMF, eat equally from both the side. Very, very important. Okay, don't eat. Already the muscles are weak. If you start eating from one side, the muscle that is crushing the food cannot take that much load. And the other muscle which is shifting the food to the other side cannot take that load. So eat light food equally from both the side and start on thermotherapy, massage therapy, coolant therapy, and strengthening resistance exercises. Okay, so there are certain resistance exercises for masticatory muscle. You can start on that.
Thank you, sir. Next question from Dr. Najmuddin. When does the TMD treatment land up in full mouth rehabilitation?
So far, none of the patient has landed in full mouth treatment, and I don't believe that any treatment, any patient may go for full mouth rehab unless 99% of the cases will not require a full mouth rehab. Because why will you do full mouth rehab? To increase the VD? Let's work with the splint. Let's increase the physiological tolerance. Why are you going to do a full mouth VD? I don't. It's only for increasing the VD, which we can do by other ways also. Which we can do by orthodontics if required at all. Most of the cases that is also not required. We can use splint. The muscles which are hyperactive, we can relax them, which can increase the physiological tolerance of the system. We have to find out what are the problems associated, why the patient has succumbed. If we can address the issues of, see, occlusion is a very small issue. Occlusion is a very important issue, but that is not the only issue. And occlusion issue can be easily treated. There are other issues of sleep, posture, nutrition, stress, which also needs to be done. You do everything to occlusion, you don't do anything about other factors, nothing is going to happen. So I am not a believer of doing full mouth rehab. It does good more to dentist than to the patient, I feel.
Thank you, sir. So just one more question for the night, sir. How to go about patients in which we cannot increase the video?
Uh, See, VD, you have to increase only in few cases, okay? If you are not able to do it orthodontically, why the patient has succumbed, there will be some muscle issues which will be involved, unless there is an airway obstruction, okay? And we need an ENT specialist to work upon that, or we need a surgery regarding that. If there is a deviated nasal septum because of that, an issue is there, we can work upon that. But most common problem which will be associated with TMDs is the muscle issue. Multiple muscle has broken down, the position, the posture of the body has changed. We can use an orthotic, balance the occlusion. We can work on the muscles and correct it. I don't see any reason for increasing for full mouth rehabs or increasing VDs otherwise.
Thank you, sir. So just one more question for the night, sir.
Yes.
Are lasers a better treatment alternative than changing lifestyle of the patient? Which would be
Sorry, I did not get you. I did not get you, please.
Are lasers a better treatment alternative than changing the lifestyle of the patient? And are lasers good for permanent pain control?
So what is a laser? Okay, see, lasers are antibacterial, they are anti-inflammatory, and they're biostimulative. This biostimulative effect also helps in relaxation of the muscles. So what we are doing is, I have read a lot about it. So we started using laser in our practice. I am using laser from a long time. So I started doing a research on that. Currently, my two of the PGs are working on laser. One is working on laser on relaxing the muscles, and the other one is working on laser for the management of mucosal lesions in the oral cavity. Both have given good results, okay? But there are some issues when you use laser with topical steroids in cases of mucosal lesion that can cause a problem. But when it comes to the muscle relaxation, we have got a wonderful result. If you compare laser with a very good analgesic like diclofenac sodium is one of my favorite analgesic, but the problem is with the this NSAID is the gastric issues which happens, okay? So it has got side effects. Laser gives the equally effective analgesic effect without side effect, okay? And it is a very good muscle relaxant also, and we see a very good mouth opening when you compare laser with the diclofenac sodium, not with the muscle relaxant, okay? It is almost equivalent to the muscle relaxant. Now the first question was, we cannot compare a lifestyle with the laser. Laser we can compare with, you know, its anti-inflammatory effect, its biostimulative effect, its comparison with the medicine. Lifestyle, I did not understand how, I mean, what that question meant. I did not understand how will be laser associated with the lifestyle. I did not understand that.
Sir, and also one more question, sir. How about patients having only root stumps all through the lower jaw and need to increase the VD asking with dental implants?
Yeah, so you have to go ahead and put the implants, do a full mouth rehab. You know, you can give the occlusion right now. You can use a centric relation and give a right occlusion. When the patient is not having any tooth, means you have to raise the VD. Go ahead and do a full mouth rehab, okay, in this case, and follow the principles of orthopedic stability. Follow the centric relation if patient is not having TMDs. Use neutral position if the patient is having TMDs, and get that orthopedically stable position and fabricate the prosthesis. That should not be a problem.
Okay, thank you, sir. And sir, and one more question, sir. The duration and frequency of laser therapy.
So usually over a period of month, if you use twice, I use my TMD therapies last for 1 month, wherein I see patients twice every week, and I give laser therapy twice every week for 4 to 5 weeks. And usually we see a very, very good result. And along with the laser therapy, I also give thermotherapy, massage therapy, and coolant therapy, which is given at home, which is done by the patient at home. So this combination of these things works wonders. So over a period of 5 weeks, twice per week should be good.
Okay. Thank you, sir. The questions were actually flooding our chat box. So sir will be answering the further questions in the next session. So once again, thank you, sir, for being with Online Dentistry. And here we come to the end of the session. So stay tuned till the next 4th Wednesday for another punching session from Online Dentistry. Thank you all. Good night and take care.
Thank you. Thank you so much. Thank you so much. I hope it was useful. Thank you also.
Definitely, sir. It was an amazing session, sir. Thank you.
Thank you so much.